Hi, everyone. Thanks so much for joining us for a special Ask the Experts Facebook Live. April is Head and Neck Cancer Awareness Month, a global initiative where we raise awareness for all cancers found in the head and neck area. Today, we have three of Moffitt's experts here to answer all of your questions and share the latest advancements on those cancers. Joining me are Dr. Guilherme Rabinovitz, a medical oncologist, Dr. Deepa Danan, a head and neck surgeon, and Dr. George Yang, a radiation oncologist. Thank you all so much for being here. And before we get underway, just a few quick reminders for our audience. Please submit your questions in the comments section, and we'll do our best to get to as many as possible. And keep in mind, we cannot offer personal medical advice or make a diagnosis via Facebook. Additionally, Facebook is a public forum, and any comments or questions asked here are visible to the public, and any information shared during the event is not protected. With that out of the way, we'll start with a question for Dr. Rabinovitz. Simply, what are head and neck cancers?
Hi, Pat. Thanks for having me here. So head and neck cancers are cancers that happen above the collarbone, but do not include the brain. Usually, brain or CNS tumors are dealt by the neuro-oncology team. Like we in head and neck, really, when people talk about head and neck cancers, we're referring to cancers that happen inside the oral cavity, like the tongue, the mouth, the jaw, like the throat, the voice box, the nasal passages or nasal cavities. It will also include like thyroid cancers, salivary gland cancers as well.
Are there any gray areas, maybe when it comes to some forms of skin cancer or gastrointestinal cancers?
So for skin cancers, we also have a cutaneous oncology team here at Moffitt Cancer Center to manage most of the skin cancers as well. Particularly, I have some interest in non-melanoma skin cancers, so we tend to see those patients as well, particularly when the skin cancers are happening in the head and neck area, where they manage it by our surgical oncology team as well, or our radiation oncology dedicated to the head and neck subsites of disease, also with the expertise. For the GI cancers, like there's a gray zone between what we call the hypopharynx, which is basically the lowest portion of the pharynx. Like the pharynx is divided among like a nasopharynx, which is the area behind the nose. You have the oropharynx, which encompasses like the base of tongue, tonsils, the soft palate, and below that area is called hypopharynx, which is just like above the connection with the upper part of the esophagus, which we call cervical esophagus. And those areas kind of a gray zone. Sometimes they're being managed by our gastroenterology oncology team here, our GI oncology team. And sometimes they're managed by us because of this gray zone. And the treatment in that portion of the cervical esophagus and the hypopharynx tend to be very similar.
And what are some of the more common types or rare types of head and neck cancers?
So the most common are cancers like that happen in particularly in the US, actually in the oropharynx, which is basically base of tongue, tonsillar cancers, the oral cavity, mouth cancers, the larynx, laryngeal cancer where your voice box is located. Those are the most common subtypes that we see here. The rare forms, we talk about the salivary gland cancers. In the US, very rare as well is the nasopharynx, which is that portion that I mentioned earlier, like which is the back part of the nose. They tend to be much more common in Asia than actually in the US, but we do see a handful of patients here a year.
I've talked about the types of cancers. Let's talk about treating them, Dr. Dan, and I'll start with you. What are some types of surgeries that we might use to treat head and neck cancers?
So there's a very wide array of types of surgeries for head and neck cancer. It can be something as small as a biopsy to locate where a tumor started, but it can also be a 12 to 14-hour surgery where we remove a tumor of the jaw and reconstruct the jaw with a bone from the leg. So there's a pretty wide variety of procedures that we do, and it's tailored to the patient and the type of cancer that they have.
And how might some of those procedures differ from site to site? Are we using robotic surgery or more traditional types?
Great question. So we do use the robot to do surgery in the oropharynx, which is the tonsils on the base of tongue. If tumors are small enough and the patient is a good candidate for robotic surgery, we do robotic surgery in hopes of sparing them additional treatment.
You mentioned if a patient is a candidate, what are some factors that you look for when determining whether someone's eligible for treatment or for surgery?
For robotic surgery in particular, it's usually the size of the tumor and whether they'll have good function after removal of the tumor with clear margins. If they do not seem to have, if they will have poor function with the amount of tissue that we have to remove, the patient's usually a better candidate for radiation.
Dr. Yang, I'd love to hear you chime in. What types of radiation are available to treat head and neck cancers?
So the most common type of radiation we use in the United States is a photon-based radiation. So that's photon is just basically a light particle. In this case, it's a high energy light particle that with the use of kind of high-end technology, we're able to shape where it goes into the body, how it targets the tumor, how it avoids things that we don't need it to treat, like your salivary glands, your spinal cord, all these other structures that live around the tumors in a head and neck cancer. The most common way to do this is something called intensity modulated radiation therapy. It's basically how we allow the radiation to be shaped in that context. Some people may be hearing more and more about proton-based radiation. It's an initiative that Moffitt's going to have in the future in a couple of years over at the Spiros campus. It's currently not something we have currently, but we're excited to bring that on board once the center does go live. That is a different type of, again, high energy radiation, again, used to treat head and neck cancers, has some different physical characteristics that are good for certain scenarios, but both are very adept at curing patients as well as avoiding the side effects that are incurred.
And how does radiation differ from chemotherapy?
So radiation works in a pretty simplistic fashion compared to, I think, some of the chemotherapy agents. Radiation works more or less by causing cancer cells to have DNA damage that they can't repair. And so we have normal cells, we have cancer cells. Normal cells, when they do suffer DNA damage, they're able to repair themselves and kind of move on. Cancer cells don't have that ability because of the way they formed. And so when they go to try to divide again, they die. And so radiation exploits the differences between the normal cells and the cancer cells to basically kill off cancer cells. It works a little bit differently from chemotherapy. I'm sure Dr. Rabinowitz knows all the mechanisms.
Now, what are some of the side effects typically associated with radiation?
So the side effects of radiation are really more localized or related to where the radiation is pointed at. So for patients with side effects, with radiation pointed at the voice box, you can expect some hoarseness. For patients where it's more in the mouth or near the saliva glands, you get more dry mouth, some changes in taste. The closer is the radiation to the skin, the more likely there can be skin changes, hair loss, beard loss, things of that nature. But it really depends on kind of each individual patient's personalized radiation plan, their own anatomy, what their tumor looks like, a whole host of features. So I think in general, those are the ones I would talk about, but there's a bunch of them that just vary from person to person.
Dr. Rabinowitz, I'll tag you in here, talk about side effects as well. When it comes to chemotherapy, does it differ based on disease site, what the side effects could be?
In general, not, because chemotherapy really talking about in terms of systemic treatment, right? So it can be given IV or oral, although in head and neck oncology, like there's not many oral therapies or chemotherapy available. Like sometimes we talk about targeted therapy, which is a different form of systemic treatment that we use as well. And those can come in oral formulation as well. But it's like the IV chemotherapy, the traditional chemotherapy used for head and neck cancers. They're given, they can produce any terms of side effects like systemically, like they could affect potentially, they can cause abnormal taste, they can cause lower blood counts, they can cause numbness and tingling sensation, they can affect liver or kidney toxicity, depending which chemotherapy you're using. So usually when you're giving chemotherapy to patients, we monitor them closely to make sure they're not having any major toxicity. We try to overcome those toxicities, either replacing electrolytes or giving more fluids to help the kidneys or protecting them against nausea and vomiting. So all of this potentially happen with the use of the chemotherapy.
And Dr. Dannon, when it comes to surgery, you're dealing with a sensitive and visible area. What sort of, recovery process is there for some of these procedures?
So it depends on the type of surgery and the extent of surgery needed. Some surgeries require a few days recovery, some require several weeks. If we are doing a major reconstruction, such as what we call free tissue transfer, where we're taking tissue from one part of the body to replace tissue in another part of the body. That can be 2 to 3 weeks of recovery, 1 week in the hospital and then a couple weeks at home.
And speech can be affected by some of these procedures, correct?
Certainly. Most commonly, it's the tongue procedures that affect speech. But our goal at Moffitt is to reconstruct the tongue or whatever part of the body we have to remove in such a way that we can maximize function postoperatively. So, the speech may be affected and eating may be affected, but our goal is to still allow patients to be able to do both of those things after their procedure.
And we have some in-house resources like speech pathologists and therapists as well, right?
Absolutely. The patients are all seen by speech pathologists and physical therapists while they're still in the hospital, and then they'll assess their needs for home, and then they can be seen either as an outpatient or with home health, physical therapy, or speech therapy.
All right, and looks like we've got some questions now coming in from the audience. The first one I see is, what are the biggest risk factors for head and neck cancer? Dr. Yang, I'll give you that one.
Sure. So the kind of most common risk factors in the past were tobacco use, smoking, oral tobacco as well as alcohol use. Those are probably in the past, many decades, the most common causes. Nowadays, there's been more HPV-related disease or human papillomavirus-related cancers, particularly of the oropharynx, or what we call the tonsils, the back of the tongue, and the soft palate. And so amongst probably the patients that we see, those three represent the largest risk factors.
I'm glad you brought up HPV-related cancers. These are preventable diseases if people can get vaccinated, correct?
Mm-hmm. Yeah, so HPV exposure usually happens in folks' teens and 20s. And so, with the current availability of vaccines, it's important to consider that for kind of the pediatric population to, for better or worse, decrease what I see in the future. Because these cancers ultimately take 30, 40 years to develop. And so getting a head start on them early on is going to, decrease the prevalence and the incidence of them in the future.
Now, I know there's been a concern over the rise in some of these HPV-related cancers in other areas like gynecologic cancers, GI cancers. Is there a concern here surrounding maybe vaccine hesitancy in recent years?
I think there's, always going to be folks that are more skeptical of things that are coming out more recently. I think the current data is certainly very strong in support of preventative measures. Particularly in the UK, there's been a significant decrease in the rates of, GYN or cervical cancers in a population that have been vaccinated. So by the same kind of idea, you would expect head and neck cancers to decrease in the near to distant future as well. So I think it's all about advocacy and kind of making sure folks are well educated and understand, what we're trying to prevent here, right? We're trying to make our jobs less important in the future.
I will add that, we can see some of the efficacy reflected in how the FDA has altered the age limit for who can get vaccines. So I think it's now FDA approved up to age 45. And 10 years ago, it was a much lower age threshold. So I think they're encouraging more people to get it because it's been shown to be very effective.
And just to add to that, but it's important to do that early on, right? Because you want to actually expose the people actually to the vaccine before they actually start with sexual activity, which is the most effective way of preventing. You have to remember that this vaccine is not therapeutic. It's not really for treatment. Once you expose, the vaccine wouldn't help. So the sooner you can get these people vaccinated. So you can start at age of 9, but the CDC really recommends age 11 to 12 years old nowadays. And Gardasil is the only one actually now approved since 2016. Actually, there's other vaccines that were approved before, but they're no longer available. I don't think so. And so the Gardasil 9 serotypes, which actually covers 9 different strains of HPV, is the one available nowadays actually to receive the vaccination. And people get before the age of 15 if they're vaccinated, and they can have 2 doses only 6 to 12 months apart. As they get older, they will need 3 shots and not only 2. Also highly recommended for patients who are immunosuppressed as well. So we have to keep in mind, and so the sooner we get these kids vaccinated, again, so we can prevent potential 6 different cancers that are related to HPV nowadays.
All great stuff on a very important topic of HPV vaccination. Getting some more questions coming in from the audience. We've got a few questions asking about signs and symptoms. So what are the first signs and symptoms of some of these diseases? Dr. Rabinovitz, I'll give that to you.
So for head and neck cancers, like you can develop like lesions inside the mouth that could be painful, they could be bleeding. You can have some sore throat, you have some change in your voice. You can have some ear pain because of tumors that happen in the throat. Actually, the pain can actually radiate to the ear, so they can develop like referred ear pain as well. Commonly, particularly we're talking about HPV, like they usually tend to be younger folks actually that present with this disease, and they usually have a very small primary tumor in the back of the tongue and the tonsil that usually are asymptomatic, but they present with like a neck lump, right? Often we hear a story like, oh, I was shaving and then I felt like this lump here that wasn't there before. Like, so this is actually a very common presentation that we see, where they actually felt some asymmetry, either in the neck or when they open the mouth, and you can look at actually in the tonsillar area or base of the tongue, they can see some different size in the tonsil or asymmetry in the mouth. So all of this could actually call attention, like to bring it to like their primary care physician, who probably going to refer them for a ear, nose, and throat or head and neck surgeon, or for the evaluation and potentially a biopsy concerning findings and imaging studies.
Now, are there any symptoms maybe in the sinuses or even cold-like symptoms that might be something to look out for head and neck cancers?
It could actually, particularly if you have something in the nasal cavity or in the nasopharynx. People can feel like their nose are blocked, but you have to remember like that a lot of this is really, it can happen to any of us. It could be just benign, and you don't have to alarm right out of the batch that there's something wrong, particularly if you develop a hoarseness, you have some flu-like symptoms or cold. We usually tell patients or people in general, like, I mean, if let's say 2, 3, 4 weeks has passed by and the symptoms persist, or they're getting worse and not improving and not getting better, they should definitely look for medical attention. So for further evaluation and workup, right? But if they develop some hoarseness, the flu-like symptoms, they're congested, even if they have like a nose bleeding that stop in 2, 3, 4 weeks, I mean, the symptoms are actually improving, went away, they're feeling better. Like, it's probably not so concerning or nothing concerning about, but they definitely need to look for medical attention if there's any questions, just to confirm that there's nothing to be alarmed at and for the workups needed.
So really, it's those lingering, persistent symptoms that we really need to be on the lookout.
Correct, absolutely.
And now, is there a way to screen for these cancers in healthy people that aren't experiencing any symptoms?
So the screening nowadays is limited to oral exam, right? So like, I mean, we truly encourage for people in general, like when they go to the dentist, to really not only like look at the teeth health, but also looking actually inside the mouth, not only looking, but also feeling from inside the mouth and the back of the tongue, and just to make sure they're not seeing or feeling anything that is abnormal, that maybe should consider to be biopsy or monitored closely or being referred to. Also, the dentist, like we're seeing some dentists actually, they're very good about like even checking the neck and feeling for lumps or bumps. I think this should be standardized. I mean, everybody should be doing that as well. So either when you go to the dentist or the primary care physician, getting a good oral exam, again, by looking and feeling, and a neck exam as well to make sure that there's no lumps or bumps. This is the best and currently the only screening test that we do that. It's not perfect, like it's hard to see what's going on, let's say, in the voice box and the larynx. We're not going to be able to see just by a clinical examining. But if, of course, there's symptoms that need further evaluation, a ear, nose, and throat or head and neck surgeon should actually see these patients as well, or these people, to make sure that there's nothing else that is missing or concerning.
And Dr. Yang, before we went live here, you were mentioning that we have clinical trials available for head and neck cancers. What are some of the different trials we have, and how can someone find out if they're eligible or get enrolled?
Sure. So your best resource is going to be for patients is the clinician that they talk to, because they have the best sense of which trials the patient would be eligible for. But just to give you a sense of what kind of trials we have available, we have trials that are headed up on a national level by the NRG, the ECOG, which are cooperative oncology groups. From the radiation side, we also have investigator-initiated trials where we have adaptive radiation, things of that nature. And certainly, that's just on the radiation side. A lot of these trials do end up combining radiation and chemotherapy, so sometimes asking more than one question. And I know that Dr. Rabinowitz and Dr. Dannon both have trials up their sleeves for a whole variety of situations that I'm sure they could, briefly discuss or comment on as well.
Yeah, Dr. Dannon, I'd love to hear about the clinical trials you're working with.
I just started Moffitt like 6 months ago, so don't actually have any, but Dr. Rabinowitz is our expert.
Yeah, so we have a variety of clinical trials, as Dr. Young was saying, and not only actually we're looking into improve survival of patients who have incurable disease and try to evaluate experimental therapies that are actually could potentially be a magic bullet that they're looking for, right? So like I mean, but not only that, but we're also trying to improve the quality of life of patients. Like when we talk about chemo, radiation, surgery, those are those treatment works, but they come with toxicity with that, right? Like so, and as we mentioned before, the side effects of each of treatment modality that we use. So since now we're getting better in treatment and curing more patients, particularly when they come at earlier stage disease, we're also trying to de-intensify therapy, right? Trying to optimize their quality of life because these patients are living longer. So we don't want them to lingering of cumulative and chronic side effects and toxicities from the treatment that were provided for potentially a cure. So we are trying to also looking into lower radiation therapy doses or lower the chemotherapy doses as well, changing the chemotherapy for something less toxic agents, right? We're looking into potentially come with other targeted therapies or immunotherapies, which drugs that actually activate the immune system or remove the brakes from the immune system to actually fight the cancer in a curative intent setting, since they tend to be more manageable and tolerable to patients than the standard chemotherapy drugs that we normally use. So there's a lot going on in the field. It's very exciting to be part of that. And if any of the patients are looking for options in clinical trials, trying to see that, I really encourage them to come by and see what's available at Moffitt, and we can guide them. And if they're not interested in the clinical trial, they can move on and standard of care treatments, whether it's here, whether it's local. But it's like it's always good to have options, and I encourage them to look into them.
Yeah, and just to kind of add on that, Pat, I think on all of our biographies, there are lists of trials that we are participating in. So kind of depending on the physician that a patient sees, that can kind of be a good stepping stone to start the conversation, kind of initiate that piece.
Yeah,
Now,
and the beauty, sorry, Pat, and the beauty here is also that we have our multidisciplinary clinics and teams. So basically, we often like seeing the patients together and coming up with the plan together as well. So, and we all work very closely to each other. So in generally, the right hand knows what the left hand is doing. So it's really a collaborative effort and to try to bring what's best for the patients that we see.
Now, are these trials available as a first or early option of treatment, or are these typically for people who have failed on other types of treatments?
We have both. We have for patients with still in the curative intent treatment, also, like I said, to also try to not only optimize the cure chances for patients, but also to decrease the toxicity of the treatments as well and optimize their quality of life without sacrificing like the cure rates. And we're also looking for patients with advanced disease, metastatic disease that unfortunately is not curable with standard of care treatment options, but either is in first line when they have not received any treatment yet, or patients who potentially had received some treatment that maybe was done outside or even here at Moffitt, and now we have a second line or potentially third line therapy for these patients as well. Hopefully it's better. Hopefully that trial with that experimental agent is going to translate to be a better therapy for what they would get otherwise as a standard of care. And that's why we're studying those drugs right now to really to try to change what's current the standard of care for these patients.
We do have a audience question in relation to clinical trials. Facebook viewer June asks if there are any new clinical trials for esophageal cancer. And that's one of those GI, maybe gray area cancers, correct?
Correct. So this is more like it may be more a better question for like the GI oncology group, because we're like really focused on the cancers in the head and neck area. And like I said, because of the hypopharynx is a gray zone in between, but like some of the esophageal cancers could be in the mid esophagus, the lower esophagus, and the histology may be different than what's the most common type of head and neck cancer, which is usually histologically called squamous cell carcinoma, which is because it comes from the epithelial cells that lines the what we call aerodigestive tract, and like this is where these cancers are formed, and 90% of head and neck cancers are of squamous cell origin. So depending really, so I would defer really that question to the GI group because they make, but like they have an array of clinical trials and studies similar to what we have in head and neck, but dedicated for GI oncology, like the esophageal, the stomach, esophagus, stomach, and colorectal cancers and others.
Now, can squamous cell carcinoma also be a form of skin cancer?
They can. I mean, like, so the squamous cell carcinomas can come from different parts of the body, right? So, like, I mean, because of the epithelial cells, like the skin cells are also squamous cells. So on skin, you can have basal cell carcinomas, squamous cell carcinomas, you can have melanomas or Merkel cells, right? So this is different types of cells that we have on the skin. But squamous cell carcinomas are kind of like general common tumors. They can happen in the esophagus as well. They can happen in anal. They can happen in many other areas also, in many other organs as well. So it's a very actually common type of epithelial cells that transform into cancer.
Now, we did get one question. I know the sun can obviously be a risk for skin cancer. Is sun exposure a risk for head and neck cancer potentially? Dr. Yang, you look like you're agreeing.
Yeah, kind of like Dr. Rabinowitz was saying, it's a risk factor for cutaneous squamous carcinomas as well as basal cell carcinomas, and as obviously melanomas as well. Those are the most common skin cancers that are associated with sun exposure. Sun exposure is not associated with the other mucosal, cancers of like the tongue or the back of the throat. Those are not related, but they happen to share the same name, which is why there's often a lot of confusion between cancer cell of the tonsil versus having a cancer on the arm or somewhere unrelated on the skin.
Yeah, and similar to what I said about like the division between the hypopharynx and the esophagus, can happen in a way of the lip and the inside the mouth of the tumors, right? So the lip cancer, like right where you have like the skin, they also have exposure from the sun as well, and those actually can be caused as well. Like I mean, so there's kind of it's right at the border, like between what is inside the mucosa, like inside the mouth also too, and the skin epithelium, right? So it's like it's and those can be affected by UV exposure.
Now, if someone comes to Moffitt with one of those, gray area cancers, how does your team work with other clinics to determine who the best, person to treat that patient is?
So the lip cancers usually they would come to us, right, as part of the head and neck area as well. So like I mean, they're commonly seen by us and managed by us. As I mentioned before, as a medical oncologist, I also have interest in non-melanoma skin cancers as well. So I end up managing them as well, like if needed, in terms of systemic therapy. But often those tumors actually are managed by surgery and radiation therapy, which is since the head and neck area, head and neck cancers are very complex form of cancers, as we mentioned before. It deals with your speech, if you're swallowing, I mean, with the breathing as well. Like, so we really want people dedicated to the head and neck area actually to manage those cancers so we can provide the possible best outcome for these patients. So because of all of this area actually and how it could potentially affect the function, not only because of the tumor, but because of the treatment that we provide as well, they end up actually being managed by us.
Dr. Dan, we've got another question here for you. When receiving treatment, or if you just undergone surgery, is that something that might prevent you from returning to work for a while?
Potentially, depending on the extent of surgery, you may miss work for a week, you may miss work for 3 weeks. But if you are having an extended treatment with surgery, followed by radiation and chemotherapy, you could end up taking some extended leave even during radiation towards the end.
And we may have touched on this earlier, but in some of these surgeries, are the lymph nodes removed typically?
Yes, and many of them they are removed, even if we're doing sort of a smaller tumor surgery on the tongue or the lip or anywhere in the mouth or throat. We oftentimes remove the lymph nodes where that tumor is draining to not only fully stage the tumor, but also to treat it.
Could that also be a method of maybe preventing recurrence, a future disease?
Potentially, we're always worried about the risk of microscopic spread of tumor. So that's oftentimes why we would remove lymph nodes, even if they appear normal on a CT scan or an MRI, because we're really trying to make sure that we prevent any microscopic spread from growing.
Are there any other types of preventative surgeries?
We don't really do much in the way of preventative surgeries, but we do some, like lymph nodes, do some additional surgery at the time of tumor removal in order to prevent recurrence.
And we've got another Facebook question going back to the subject on HPV. Do you know what the stats are on HPV cancers being recurrent? I will throw that out to the group. Anyone wants to answer that?
So the question is like, go ahead.
Like how often do HPV-related cancers recur?
Oh, okay. Yeah, HPV-related cancers tend to respond better to the traditional treatments of chemotherapy, radiation, or surgery, and so they tend to recur at lower rates compared to the classic kind of smoking and alcohol-related cancers. So I would probably quote about a third of the relative recurrence risk compared to the classic ones. Those numbers are a little hard to throw around just because in general. Depends on the stage, depends on the volume, depends on where it is, things of that nature. But in general, they recur less often.
Well, it is coming up on the end of our time here. I'd love to give each of you a chance just for some final thoughts. It is the awareness month. What do you want the biggest takeaway to be for our viewers here? Dr. Yang, we'll let you start.
I think if for folks that have head and neck cancer, you're not alone. There's a lot of folks out there who have struggled with cancers, battled and fought and won. Your head and neck cancer doctors are your best resource, whether it comes to your diagnosis, your side effects, the different treatment options are available. So come to us with questions, and we will provide answers, and we'll try to get you the best possible care that we can.
Dr. Dan, and I'll go to you next.
I will add that prevention is key. So if you're a smoker, we have options to help you stop smoking. Dental hygiene, really important. Taking care of your teeth is really important in preventing some tongue cancers. And if you have children, grandchildren, or you're under age 45, the Gardasil vaccine, also very important.
And Dr. Rabinovich, your final thoughts.
I think in general, the oncology community is getting better, right? Like, I mean, I know cancer is a scary word for everybody, right? So, and we all either met somebody in our family or friends or ourselves actually developed cancer. Like, so we all been touched some way by cancer, right? So, and I know how scary that can be. So, and I just want to let you know that things are actually continues to improve. And things today are much better than they were like 10 years ago, right? So, and we have many options, and you understand much better the disease process than we did in the past. And that's coming more research, more studies, new drugs, new developments, new approvals. So, and I'm hopefully, like for those who unfortunately cannot be cured, this will become truly chronic disease, like we're living with diabetes, like we live with high blood pressure, and hopefully we're going to do the same way with cancer as well, so people can live their lives doing well with the cancer on hold, or potentially actually getting more and more patients getting cured, particularly in advanced disease, right? But the key is also identify this early on. So not only prevention is the key, like but identifying the cancers early on, it's your best chances of curing that. So please follow up with your primary care physician, with your dentist, monitor yourself actually for any changes that happen that you may be concerned about it, and don't just hesitate to bring it to your primary care physician, to us, or anybody actually attention, so we can actually do further workup and make sure that there's nothing else that's missing, because the majority of cancers in early stage, not only for head and neck, but in general, actually can be cured. So let's find them early on if they happen to develop on ourselves.
That's a great note to end on. Thank you so much for our panelists for answering all these questions today. And thank you to everyone for watching and submitting your questions. For more information on HPV prevention, you can visit moffitt.org. If you want to be screened for head and neck cancer, we are offering free screenings at Moffitt this Friday from 8 to 11:30 in the morning at our head and neck clinic, located on the first floor at our Magnolia campus. Thanks again for watching.